Welcome to Charting with Dr. McNeil. Greetings, this is Dr. McNeil, and we are about to launch into Charting with Dr. McNeil. This series is relatively new. The idea behind it is to educate the public and our physician community about the offerings at Adventist Healthcare and introduce you to some of our most stellar physicians that we have. This day, we're going to be talking a little bit about the neurosciences, stroke, epilepsy, a lot of the diagnoses that the public is familiar with and are very difficult to treat and are challenging to have a good quality of life if you happen to have those diagnoses. And so today I am very fortunate to be here with two of my very favorite physicians. I'm a physician's physician who likes physicians, but I'm talking about two that are truly my favorites. And I'm going to have them introduce themselves. Dr. Segunis.
Thanks so much for having me, Dr. McNeil. It's an absolute privilege. And like you mentioned, I'm happy to be here with Dr. Smith, but I'll introduce myself first. So I'm Dr. Dimitri Segunis, and I'm the chair of neurosurgery at Shady Grove Medical Center and the chief of neuroendovascular surgery for the Adventist Healthcare System.
It's awesome. We're going to talk a little bit about what that means in just a little bit. And I'm going to go ahead and go to Dr. Perry Smith. Tell us about yourself.
So I'm Perry Smith. I'm a neurologist. I am the head of inpatient neurology and stroke care at Shady Grove Medical Center. And I've been there for about 13 years now. Time really does fly.
That it does. Remember when you came. Well, let's get started and launch into the meat of this conversation. Let's talk about neurosciences. Before we actually talk about neurosciences, I want to get a little bit more background on you all. You all chose some of the most interesting specialties in medicine. One of you, the neurosurgeon in the room, chose the specialty with the longest training time in medicine as well. I want you each to tell us a little bit about your training, why you went into the specialty you went into, and what you love about it the most. Dimitri, it's all yours.
Thanks, Patsy. So I went into neurosurgery being interested in the brain in general. I thought it was a fascinating organ, something we didn't know very much about. And because of the potential for technology developments, I chose neuroendovascular surgery. So that basically means that you go into neurosurgery knowing that you're going to do 7 years, but then additional fellowship training is a 2-year process. I was at New York Presbyterian at Cornell for both my fellowship and my residency. And then afterwards, I came down to this area, to the D.C. area. I have an academic appointment at George Washington University Hospital, but I've been with Shady Grove for almost the entire time that I've been here. And I've basically helped build the neuroendovascular surgery program along with Wayne Nolan, with Dr. Smith, and with an amazing group of people. So neuroendovascular surgery basically involves stroke care, especially when you have to do something to be able to treat a blood vessel that might be blocked. We'll get into that in just a little bit. But any problems that the brain has that involve the blood vessels fall into that same category, and you do it in a minimally invasive way. So you basically use x-rays and you use small plastic tubes called catheters to be able to access these blood vessels and then be able to treat the problems.
Amazing. Now, talk about that more over time. Talk about stroke in general and the global impact and the United States impact as well. But Perry Smith, you have had, I learned just a couple of years ago, a very interesting pathway to medicine as well. Now, Dr. Segunis just talked about 9 years post-medical school in training, which to me is like, that's quite a bit. Having said that, though, talk about your training as well and a little bit about you and your decisions to go into neurology.
Yeah, so like Dimitri, from the time I was a kid, I thought the brain was really interesting. When I was a kid, I read a book called The Man Who Mistook His Wife for a Hat by a guy named Oliver Sacks. And I something clicked in my brain when I read that. I was like, wow. This is like the most interesting thing possible. And I thought, if I did this for a living, I'd never be bored. And it panned out, That's exactly what I do for a living, and I'm never bored with it. The pathway for medicine, it's a long one, right? So I read that book when I was maybe 10 or 11 years old. I was a kid when I read it, And then I went to college. I realized that what I needed to do was go to medical school, probably about junior year in college. And I heard about this thing called an MD PhD program where you could we could do research while you were in medical school and get a PhD and an MD at the same time, and the government would pay for your medical school. I was like, ooh, sign me up for that. So I did that. I got a PhD in molecular biology. And then I did a neurology residency down at Yale. And then I did 2 years doing brain tumor research at the NIH. And then my wife and I had a kid, and I decided, well, it's time to get a real job. And so, you guys were hiring. And so I got a real job here, and that's the whole story.
That is the whole story. Both of you guys make me feel like I need to go back to school and work a little harder, because that's a lot of schooling. All right. Now, tell me a little bit about what keeps you inspired in these specialties. I'll say, Dr. Segunes, your specialty, when I was in training, did not even exist. So first, decided at Shady Grove to go ahead and incorporate that into our abilities to offer our community. It was exciting for me because more and more, the older I get, there are these specialties and these things that come up that literally, didn't exist when I was in training. It wasn't that long ago, but it was long enough to see change. So tell me about what you do, the cutting edge parts of it, and we'll also talk a little bit about stroke. And before you do that, stroke is something that has a global impact that is profound. 12 million people a year have strokes. Large amount of death and disability, a lot of profound life deterioration as far as enjoyment of life when you have a stroke. And you do the type of work, and Dr. Smith does as well, where you literally pull people back to the point that they have almost no deficits. And it's a beautiful thing to see. The first time you see it, it's almost like sorcery. It really is. It really is amazing. So talk about your specialty a little bit more, about some of the types of things that you do, the time course, how profoundly impactful it is for our community as well.
Yeah, absolutely. That kind of cuts to the core of why we do what we do. So I was talking about neurosurgery training, and along the way, I thought neuroendovascular would be a good option. And at the time, we were treating diseases of the blood vessels by, ever since neurosurgery started 100 years ago, you would open up the skull, you would go find what was problematic and try to fix it that way. But neuroendovascular started maybe in the early 90s, where you basically take a small plastic tube, like I was saying, you make a small hole in one of the blood vessels of the legs or the wrist, and then you go up using x-rays to try to treat that problem. So neuroendovascular has been around for a little more than 3 decades. And specifically, stroke care always involved giving medicines. So if you have a blockage in a blood vessel and you're not getting blood flow to a part of the brain, then you try to open up that blood vessel by giving medications that can break that up. And Dr. Smith, I'm sure, is going to talk about that in just a little bit. But in 2015, we realized that if you go in and you actually unclog that blood vessel, sort of like a plumber for the brain, you're able to restore that blood flow, and you can have a pretty profound impact. What Dr. McNeil was referring to, patients that are rapidly having brain cell death because of that blockage and the lack of oxygen that goes to that part of the brain, because blockage causes blood flow not to go normally. That can really, over the course of an entire stroke, if you don't solve it, that can cause decades worth of damage to the brain. So, you would see a patient who is basically having a significant stroke. You unblock a blood vessel that's causing that stroke, and suddenly that patient goes back to normal by the next day. I mean, there can be nothing more rewarding than seeing something like that and knowing that you had some part to play in that. So, neuroendovascular surgery has really changed the way that we do things. And the fact that we've been applying this technology, it came onto the forefront maybe in 2015, but we started our program at Shady Grove shortly thereafter. In 2018, we were able to get that program started, and since then we've been building exponentially. And what we've been able to do for our community, I think, is just something that I don't see anywhere else, in terms of the ability to say, look, this is a public health crisis. We need to be able to address it. We need to have buy-in from the nurses and the techs and the doctors that are part of that care, from when the patient comes in the door in the emergency department to when they're discharged from from our intensive care unit, our floor, our rehab centers, to have that sort of passion for making patients better and taking pride in that is something that is incredible to witness at Shady Grove.
It absolutely is. In 2015 was a hair's breadth away. It was not that long ago. And so when I say that this is relatively brand new, though things started in the 90s, as far as practical application in a community in Montgomery County, this is light years of progress in a very small amount of time. And it's just a profound offering to the community. Now, like I said, when you see somebody come in and they can't move a right side or can't move a left side or can't speak, and they are given into your hands, into our lab to be able to open that up, and you see them shortly after and they're well, it's just it's such a fulfilling career. But stroke care in general can be the same. Now, when I was in training, the studies that were being done in Cincinnati for using clot-busting drugs.
Yeah.
Let's talk about that, because the public needs to know as well that it's important that they have symptoms, they get treated quickly, and if they don't, they can have permanent damage. But talk about your work a little bit too.
I mean, that story really starts in sort of the late 80s, early 90s. And historically, there wasn't a lot you could do for a stroke. 100 years ago, you had a stroke. That was kind of it. In the late 80s, they realized that you can break up clots, that you use medicine to dissolve clots. And the applications for this were immediately heart attacks and stroke. Turns out that doing the studies for heart attacks is a lot easier than doing the studies for strokes. Heart attacks are a lot more homogeneous. Every stroke is different. And so it's just a real logistic jump to be able to do clinical trials on acute stroke, how to grade people. This was the same time when CT scans and MRIs were really coming into their own. And so in the mid-90s, I think 94, were the first trials with a medicine called TPA, tissue plasminogen activator. That was the first clot-busting medicine that was shown to help with strokes. And the way that the medicine works, if you take someone who's having an acute stroke, there's a very narrow window when it works. You have to really get to the hospital. We have to sort of administer this drug within 4.5 hours of the symptoms starting. If we treat people with this medicine, treat 100 people with this medicine who are having strokes, we can make about 33 of them better. And we can make about 3 of them worse. This medicine, it's a clot-busting drug. It's a very powerful blood thinner. The side effect of it is bleeding. There's no such thing as a medicine without side effects. That bleeding is often trivial. If you bleed on your gums or bleed in your IV site, that's not exciting. But you can bleed in your brain. There is danger from it. If you look at the math, the benefits far outweigh the risks. That medicine made a real difference. In the late 90s, early 2000s, they started working on doing endovascular therapies for stroke, going in through the blood vessel and delivering these medicines, giving the TPA through the blood vessel, seeing if that would help. Going out and trying to pull out the clot. They had all these devices. There was something called the Mercy corkscrew device, which would sort of, you corkscrew it into the clot and pull it out. And it was clear that was sometimes effective. But it's very hard to do large, rigorous studies on stroke because every stroke is different. In the early 2010s, I think in 2013, they came out with a bunch of trials showing that endovascular therapy didn't work. And everyone said, this is crazy. We got to do a real study that's rigorous that will show us work. And it turns out it's all about how you select your patients. And using advanced imaging technologies, something called a CT angiogram and CT perfusion studies, which weren't widely available really until the 2010s. You could effectively identify patients that would benefit from these procedures. And what the data shows is that if we take 100 people who are having these kinds of strokes, who are eligible for a thrombectomy, and we do a successful thrombectomy, 50 of them will be independent within 90 days. Right? So there is nothing in medicine that has that kind of odds ratio going for it, right? So 50% of the people get better, and these are people coming in with humongous strokes who would not naturally get better from this. That is, I say that, that is about the same as parachutes for skydiving, right? It's just that effective. And like you're saying, like Dimitri's saying, when you see it work, it is so satisfying. It's like unclogging a drain. And you often see patients get better by the same day, by the next day. And even if they're not better by the next day, you see a lot of improvement within the first 90 days. So it's just like stroke went from something that was 30 years ago, this was an untreatable condition. There was nothing to treat it. And now we have an intervention that will help a huge percentage of the people that were doing it. When we first built this program, we see about 350 to 450 strokes a year at Shady Grove. And when we first built the machine, when we first got called the biplane machine, the X-ray machine that helps do it, I'd sit down the math and think, I think we'll probably use this about 7 times a year, right? And for 7 times a year, it's worth it. If we can save 7 people, wow, that's great, you know? Last year, we did 52 of these procedures, and we're on track to do even more this year, all right? So like when you have a hammer, your problems start looking like nails, right? So when you find that you can help people with this, you just want to do it more and more.
I keep saying this, but I think the public needs to know a couple of things. Number one, you have 4 hours. Okay, 4 hours. So if you have an arm that's not quite working right, or you can't see well, you're fumbling your words, you can't speak or walk properly, it's not the time to go to bed and shake it off. This is not a shake it off type of problem. This is a get up.
Yeah, well, while we've got an audience, we want to sell that for a second, right?
Yes.
So we see a lot of times that people don't, when you have a heart attack, you feel like you're dying and it feels awful and you want to come into the hospital right away. When you're having a stroke, it doesn't feel bad. It's usually not painful. You don't have a headache. You're just like, that's funny. And so a lot of people, when they're having a stroke, they'll call their friend who's a nurse. They'll call their brother-in-law. But a lot of people don't think to call 911. So like we're trying to get the message out that if you think you're having a stroke, call 911. Just get to the hospital. We're open 24/7. Like don't worry about bothering us. Like just come. So how do you know you're having a stroke? The American Heart Association has this acronym that they're trying to spread, and it's called B FAST. So B stands for balance. E stands for eyes. If there's a sudden change in your balance, your vision. F stands for face. If suddenly your face is drooping. A stands for arm, but it also stands for leg. All right, so if one of your arms or one of your legs is weak. S is if your speech is suddenly slurred. Then T, it's time to get to the hospital. All right, so that's what we're trying to. That's the message we're trying to spread, and that's what we're trying to make people aware of. So, like, if you think you're having a stroke, be fast. Just call 911 immediately, because if you get to the hospital quickly, there's a lot of interventions we can do. But if you don't get there until the next day, the ship has sailed on treatment often.
100%. And we've all seen that over and over again. It's always very sad to see, for sure. Now, 2 things I'm going to touch on real briefly. One, the statistic is that 80% of strokes are preventable. So for everybody listening to me right now, it's eat a Big Mac, put it down. Put it down. You need to make sure that you are doing the things that you need. Take care of your diabetes if you have it. Take care of your hypertension if you have it. Eat better, drink better, be better as far as taking care of your health. In the 1-2 punches that we all know to do but don't want to do. Just make sure that you're taking care of your health. Any extra pointers there, folks, to make sure that people
I want to reiterate. So everything that Dr. McNeil said is correct. But you got to take care of your hypertension. You got to take care of your diabetes. You got to not smoke. Smoking is a huge one. A lot of people ask me what diet recommendations are, and it's surprising. The diet recommendations are eat more fruits and vegetables. 5 servings of fruits and vegetables a day. You do not have to lose weight. Although if you eat 5 servings of fruits and vegetables a day, almost everyone is going to lose weight doing that. But you don't have to lose weight. You don't have to become a vegan. You don't have to give up gluten, right? Just more fruits and vegetables in your diet. And a lot of people, your risk of stroke is independent of your weight, more or less, right? So like if you're listening to this and say, I can't do it, I can't lose, don't worry, you don't have to lose weight. Just eat more fruits and vegetables, that's all. And the exercise guidelines are maybe surprisingly, walk half an hour 3 times a week. You do not have to train for a marathon. You do not have to do P90X. Just walk for half an hour 3 times a week. All right. And that's something that almost everyone can do that. You don't have to walk fast. You just have to walk. That's it.
Those are great recommendations. And for the fruits and vegetables, people take for granted that they're eating 5 servings. It's actually, if you pay attention to your diet, you can go a couple days.
Yeah, no one in America eats 5 servings of fruits and vegetables a day. If we did, we would run out of fruits and vegetables. All right, so like just do your best. All right, I have this conversation with 7 people a day, and it's hard to eat. It's not easy to eat 5 servings of fruits and vegetables, but it's something that you can do. It's hard to quit smoking. It's very hard to quit smoking. People smoke. It's so hard to quit. But eating 5 servings of fruits and vegetables, that's doable. That's doable. I mean, so
Yeah.
it's always easy to focus on things that you can do rather than things that you shouldn't be doing,
I agree.
So.
I agree. Now, we're going to talk to a little bit of a sadder tone, and then we're going to go on to some of the other areas of neurology and neuroscience. So, sadder tone is the one thing when I was in medical school back in the olden days, the difficulty was, well, look, you're laughing, but the truth of the matter is I remember streptokinase. I am that old. So just for the docs on the audience and for you too, I remember it. The thing is that back in those days with a lot of these diagnoses, there really was no real treatment. And so there's a lot of devastating conversations that can occur with people, but there's still some that you guys are having to make with folks. How do you approach those? Just tell us a little bit about that in that, what is your philosophy about telling people, the kind truth? And as physicians, it's the hardest thing we do. It was my least favorite thing to do is to talk to people about the bad outcomes that are permanent or a death, families and everything. But tell us a little bit about your approach, because I think I've seen both of you do things like that, and you're kind and clear, though. And education of our public and the patients is always important.
Yeah, so I'll address the sort of the acute first line conversations, and then Perry can talk about what comes next after you kind of have a sense for what the outcome can potentially be. So the conversations that I have, as you mentioned, Patsy, are patient is first coming to the hospital, and we've seen a CAT scan that basically shows that there is a blockage in a blood vessel, a CTA that shows a blockage in a blood vessel, and a perfusion scan that shows that there's salvageable territory. And I mean, this happens on a biweekly, tri-weekly basis. We see patients that are in that window of opportunity to be able to go in and try to salvage some brain. And when we do see that scenario, then the first thing to do is talk to the family and say, look, from what you know about what your loved one would be potentially willing to live with, what would you think that their wishes would be in terms of trying to have a procedure done to be able to salvage a part of the brain that may have already had some damage? Every minute that you're having a stroke, you lose 2 million neurons. Well, that can add up quickly. So obviously time is of the essence, and you're having these conversations in the middle of the night a lot of times. I was going to say earlier, because like Perry said, we're open 24/7. Getting to the hospital is essential. Perry is probably the only human being that I can talk to at 2 o'clock in the morning and not get in the slightest bit aggravated at the fact that I'm getting called about something which I know is very, very important and needs to happen. But I'll have these conversations with the family, and they're not ready to maybe have these conversations, but they need to be able to make a decision quickly. I can tell you, in the last month, I had a conversation with a family that their loved one wouldn't want to have a breathing tube permanently. And so the question was, do we proceed or do we not? We decided to proceed, and I'm so glad we did. The outcome was fantastic, but that's not necessarily the case all the time. So the family needs to be prepared for the fact that there can be permanent deficit, meaning there can be weakness, or can be issues with the ability to produce or to be able to understand speech. And if somebody's read any literature about happiness and your ability to adapt to a changing situation, I mean, sometimes what we project that someone would not want to live with can be very different from what a loved one would want to live with. And so I think that those issues, sometimes later on, you reflect back and you say, okay, this was the right decision, or, in some situations, this was less frequently, this is the wrong decision. But I think that, that's the perspective from the front lines. We talk about something that needs to be decided immediately, but then Perry will talk about things on the after things have settled.
Tell me about it. I've seen you do this as well, and you're so passionate about what you do. And you are kind, but you are direct, because this is not something you can really tiptoe around.
Yeah. So the most important principle in medical ethics is patient autonomy, right? Here in America, the patient has the right to do what they want done to them. It's not what I think is a good idea. It's not what, your wife thinks is a good idea. It's not what your kids think is. It's what you think is a good idea. And in order for us to be respecting patient autonomy, you have to have a full sense of what the options are, right? So I think that the truth is the truth, right? And sometimes I say, I wish I could sugarcoat this, right? But there's just no way to sugarcoat neurologic outcomes. Like, you just have to be direct about them and say, and then without the truth, people can't make informed decisions, right? I think that one thing Dimitri pointed to is that, a lot of times people will think and say, I would never want to be, not have the use of my arm. I'd never want to not be able to walk. And I think there is, for better or for worse, I think there's a lot of ableism baked into medicine, right? And that, the idea is that it's better to not be disabled than to be disabled. And it's kind of hard to get past that sometimes, right? The great philosopher Mike Tyson likes to say that everyone has a plan until they get punched in the face, right? And it is one thing to talk about what your wishes might be when you're sitting around the dinner table or when you're at your primary care doctor's office talking about your advance directives. And it's a whole nother thing when it's the middle of the night in the emergency room and you got to make a decision, right? And I think that it always pays to talk about these things with your primary care doctor. It always pays to have advance directives, but it's like a whole nother thing when it's actually happening.
It's tough. It's really tough. I've seen families struggle with that for decades. It's very, very tough. Yeah. We're going to switch a little bit from what your bread and butter usually every day is and go to neuroscience in general. We're going to talk a little about AI and tech and what's coming up because that's what everybody wants to hear about, of course. And then we're going to go into things like Alzheimer's and multiple sclerosis and some of the other diagnoses. So we're just going to launch into the tech first, and we'll back into some of the other diagnoses that are around.
Yeah, Dimitri's got all sorts of cool tech stuff.
I know.
He's got
a
lot
of
cool
toys,
things.
all the expensive toys. So go for it. Tell us what's in the future and what's in the present a little bit.
Yeah, we had I remember a lively discussion over dinner, guys, a few months ago, where we were kind of talking about what the future of this field is going to potentially look like. And obviously, being in neuroendovascular surgery, you see a lot of technological advancements, and I'm very excited about the possibilities. I'm not sort of a pessimist about the direction where humanity is going, because I think that these tools are going to be incredibly useful to be able to overcome some of the problems that we are facing from disease processes that can take away our abilities to do certain things. So one of the most exciting parts is brain-computer interface in neurosurgery. So brain-computer interface basically means, putting in some device inside the brain that's able to control an external device, whether that's a computer, whether that's, an exoskeleton, whether that is a prosthetic, some way to basically use thought to be able to project it outwardly without needing use of your hands or your voice, for example. So basically, you think it, and it goes directly to a screen. There are competing companies out there in this space race for brain-computer interface. From a neuroendovascular standpoint, there's one that is doing clinical trials in the United States where you can basically implant a device in a vein in the brain. And that is able to collect these signals through the blood vessel wall and send it to a computer. And this is done in a minimally invasive way. You don't have to open up the skull to be able to do it. And we've had discussions with Perry about enrolling patients at Shady Grove for this clinical trial that's opening up. Because again, for a patient that has a type of a syndrome called locked in, where you have a stroke in the base of the brain, and you're not able to move anything except your eyes, to be able to do activities of daily living by just thinking about it, like online banking, texting friends, controlling devices around the house, that's essential. That leads to the connectedness that we need in our lives to feel human. So what is going to be the future of this field? Who knows? But I think that being part of the conversation is absolutely essential, and it will happen. It's just a matter of who's going to do it best and when.
I'm going to tell you right now, I have a mixture of alarm and excitement. I want to simultaneously just yell "IE" and run up from the room, and I also want one right now myself. So I'm just putting it out there. It is a mixed feeling, right? To have something foreign put, in your brain, obviously with something severe like locked-in syndrome, and some other things. 2 years ago, in 2023, I went to the Global TED Talks in Vancouver. You ever get a chance to go, I highly recommend it. And there was a lot about tech and AI at that time, and they had someone whose name I cannot recall, a scientist who had done this exact thing, and there was somebody who was in a wheelchair who couldn't speak, who controlled a drone and flew it around the theater, and it was just shocking. It was just shocking. And so the future looks bright as long as we kind of put some boundaries around some of the, the tech a little bit. But what do you think about all this, and what are the tech?
I think something in medicine have proceeded so fast. It's like a blink of the eye, and oh my God, we're doing it, right? So like these thrombectomies, in 2010, they were a pipe dream, and now they're like a reality. We do them every day, right? I always think about Christopher Reeve, right? So like Christopher Reeve's accident, was that 95, right? 94. And I really thought that within Christopher Reeve's lifetime, there would be, the prosthetic technology would be there that he'd be able to walk. I really thought that would happen. And it's been 30 years, right? And it's not there yet. I kind of think it's around the corner, right? I think that we're in a time where we don't even need a big technology leap, right? That the science that controls our phones, the science that, that these drones, they can control a leg, right? How hard can that be? We're not there yet, but I feel like we're closer than we've ever been.
The pace of this is astounding. I think, instead of a pace of 10 years, a pace of 3 years is probably the equivalent, and I'm making that up, audience. Don't chat GPT on me. But the pace is really sped up, and I think you're absolutely right. There will be a lot of change. A lot of physicians think that it will replace us. My thought is it will not replace us. It will enhance us. When you're a kid and you're looking at Star Trek, you're like, when is it going to happen? When is it going to happen? When is it going to happen? I am a secret Trekkie. I am. I think it's around the corner. I really do.
Yeah, Patsy, I completely agree with your timeline. And the reason I'm saying it is, you can look at advancements. Talking about Neuralink having implanted 10 patients, that's pretty recent. The other company that I was saying that does it neuroendovascularly has also implanted 10 patients, but since 2019. So we have 20 patient years worth of data saying that this works. One of those patients wrote a book by thinking about it.
Oh, my goodness.
So we're getting there, and it's going to be sooner than what we all think.
Right. Magic, folks. Magic is happening in here as far as medicine is concerned. So that's really exciting. Now, let's talk about some of the other diseases. I have to be honest, I don't know of much progress, and I'm looking for information from you guys. MS. The drugs have gotten better.
Yeah, so the drugs have gotten better. Yeah. The drugs have gotten better. It's another thing that when I was in medical school, we had medicines that just did not work.
And muscular.
Right.
Tell me the whole.
So multiple sclerosis. It's an inflammatory condition of the nervous system where people get attacks of inflammation, which can add up and cause disability. We now have treatments that actually work, that are effective. And so when I was in training, I'd see 2 or 3 patients with multiple sclerosis a week who would come into the emergency room with breakthroughs and flares. And we have to treat them with steroids, and they'd need rehab. And now I see 1 or 2 a year because the medicines are just so effective and so easy to take. And it just quiets the medicines we have. This quiet down your immune system, and people stop having flares. So like that's really been that's a story in the last 5-10 years. Again, that the trajectory of treatment for these kind of conditions has just changed,
Talk about Alzheimer's. And this is
Alzheimer's. That's a little bit of a less heartening story, So Alzheimer's disease, it's a disease that affects people as they age. Your brain cells that are involved in memory and other things start to die off. And this is a terrible disease, and it's a huge burden. And if there was some medicine that could stop this or slow this down, it'd be humongous. One of the pathological things that they find in brains with Alzheimer's disease is something called plaques. They find these plaques. And since I've been in medical school again, the research has been focused on clearing out the plaques. If you could find some medicine to clear out the plaques, the patients would get better. And this seems to work in rats It seems to work in monkeys. They've been trying this for 30 years. We haven't gotten the effects we want. And my concern is that with Alzheimer's disease in particular, by the time you're showing signs, the ship has sailed, right? So there may be tweaks. There may be things that are better. This is something where stem cells might work. I have more pessimism in my heart about fixing Alzheimer's disease in the next 5-10 years than I do about fixing multiple sclerosis, right? It's
unfortunate.
It's a little bit less of an optimistic story in the year 2025.
There are some studies around preventive things. The way your diet, your community, having a sense of community, all of these things help. They're not slam dunks, though. There are some genetic factors and so forth as well. But there's a lot of noise out there about, once again, how you eat, making sure that you have your right omega-3 mix and you have what you need. Looking around at everything, I certainly sprinkle hemp seeds in a lot more of my food than I used to. I'll be honest. But it is something that is a devastating disease. And with the aging of the community in general, it's about to land like a neutron bomb, I think, on the world, because there's a lot of older people out there. What other diseases can we talk about? Epilepsy. There's a lot of neurosurgical things and medication things that are happening in those. Test it to you, Dimitri. There's implantable devices and things there too.
Right. So for epilepsy, I mean, we again have devices that can be implanted on the surface of the brain to be able to detect seizure foci. They're becoming smaller and smaller, and some of these same brain-computer interface companies are basically looking at implanting what they're developing to be able to collect electroencephalographic signals, brainwaves, to be able to also collect information about seizure foci. And so, what that is going to lead to, the devices are getting smaller and smaller. There's also a push to do this endovascularly. Like we said, I mean, if you can access blood vessels in the brain and you're able to access places where seizures can happen and collect signals, you're able to kind of not have to go down the route of open brain surgery to be able to treat seizures. And not just collecting signals, but stimulating parts of the brain that can lead to those seizures getting short-circuited and to prevent seizures. So epilepsy, I think, is also a disease process that's definitely going to be on the upswing in terms of what we're able to develop, as is deep brain stimulation for diseases like Parkinson's.
Parkinson's as well. Yeah, another devastating disease, or it can be with folks as well. We have covered quite the swath of diseases, all of which we treat here at Adventist Healthcare. Our neurosurgical entity site predominantly is at Shady Grove, and you guys are right in the center, in the thick of it all. And so I have to thank you guys for all the information you've given. Any final closing thoughts for the public that you would like to say? And for anybody listening who has a son or a daughter who's thinking about going to the neurosciences, what can you tell them?
Yeah, I'll say that having kids that are getting to the age where they're starting to look at future professions, talking with friends, shadowing. There's a lot of burnout in medicine, but I can tell you that it really has to do with how you structure your career, your priorities outside of work, making sure that
Agreed.
you're happy with the role you play in society, and being happy where you work. And I can say that, Shady Grove provides a group of people that really do take pride in their work, and they want to be able to help. And I'm always, I was saying something to somebody about a month ago, that I look forward to going to work. And being able to say that means that you're not going to get tired of it anytime soon. But you need to be able to make sure to balance having time for what makes you happy outside of work, and also making sure that you stay interested. And I think that's what neuroscience is for me. There's so much potential that I it hasn't gotten old yet, and I don't think it will for quite a while.
Well said. Both of you two, when I see you and there's a case going on, you guys look lit from within. It's a little creepy. I have to say it out loud. But you are exactly who I want taking care of me if I have a stroke. Perry.
Yeah, I mean, I sometimes say I like my job more than anyone I know likes their job. I get to meet new people every day. I get to solve problems. I get to help people. I can't fix every problem, but it's just a tremendous privilege to be able to do this job, and I feel lucky to be able to do it. And I don't know what the future of medicine is. I don't know what healthcare is going to look like in 10 years, 20 years, but I think there will always be disease and pestilence with us,
Unfortunately,
and,
yes.
there will always be people who want to stamp that out, and so I think that there'll always be a role for people who want to help people in this world.
Marvel films are very, very popular right now. In fact, I wish they would cut it out because I've seen The Avengers 25 times in 3 different ways. I'm tired of it. I think the true superheroes are in this room with me right now and across Adventist healthcare practicing and taking care of patients. I think the public needs to know that. They need to understand it's not how far you throw a ball. It's not how fast you run. It is not the fact that you can act like somebody you are not. It's the fact that you're taking care of human beings and doing it exceptionally well, which you do. And so I thank you on behalf of Adventist Healthcare, and in fact, in part of my own self too. I will be looking for you when I'm 80. And have a
you should take care of yourself. You should only stay healthy and never need our services.
I agree.
But I want to push this be fast thing one more time for anyone who's listening.
Please.
If you think you're having a stroke, and be fast, balance eyes, face, arms, speech, time to get to the emergency room, call 911. We're open 24/7. We're always on call. There's always someone there. And if you need this thing in the middle of the night, we'll come in the middle of the night and fix you. So.
Absolutely. Thank you very much.
All right. Thanks so much.
Thank you.
Charting with Dr. McNeil.